Olá, pessoal. Nós vamos começar agora o módulo de próstata após ASCO GU. Eu tenho o prazer de estar comigo, meu amigo Adriano Silva, aqui do ICTR em Curitiba. E we have the great pleasure to be here with us, Dr. Neeraj Agarwal. Dr. Neeraj Agarwal is a medical oncologist at University of Utah, the Huntsman Cancer Center. Neeraj, thank you very much to accept our invitation. We will present I have two presentations, the Adsense trial and Preside trial, and then we can discuss these two trials, and my friend and my colleague Adriano will present Propel and Magnitude trial, and we discuss both trials after that. So I'll do my presentation in Portuguese, and we can discuss in English right after my presentation. Thank you.
Thank you very much, Andrey. It's a pleasure to be here. Thanks for having me.
Thank you. Bom, vamos lá. Eu vou começar a minha apresentação, pessoal, falando um pouquinho sobre o que a gente já comentou um pouco mais cedo, que é o estudo Adsense. Acho que a gente já está subindo ele na telinha para vocês. Esses são meus conflitos. Bom, o estudo Adsense já foi comentado. Esse é um estudo que avaliou a população com câncer de próstata metastático sensível a hormônio. Para receber 1 para 1 tratamento padrão aqui com bloqueio androgênico mais docetaxel com ou sem adição de darolutamida, e o endpoint primário desse estudo era a sobrevida global. Quando a gente avalia o que foi apresentado na ASCO GU e publicado no New England, a população tratada é uma população basicamente de pacientes com câncer de próstata sensíveis à castração. A gente destaca que 85% mais ou menos desses pacientes tinham a doença diagnosticada como metastática, mais ou menos 15% era doença recorrente, e o resto das características muito parecidas com os pacientes de diversos estudos nesse cenário de doença sensível à castração. O endpoint do estudo foi positivo, então houve uma redução do risco de morte da ordem de 32% para os pacientes que adicionaram darolutamida ao combo de ADT mais docetaxel. A gente consegue ver que basicamente todos os pacientes tiveram o benefício da adição dessa terapia. E o que a gente consegue ver é que esse benefício ele aconteceu a despeito de um bom número de pacientes recebendo terapia subsequente, terapias prolongadoras de sobrevida. Inclusive, aqui nós estamos colocando no braço de, entre aspas, placebo, né, ADT docetaxel e placebo, onde 75% dos pacientes receberam alguma terapia subsequente prolongadora de sobrevida. Desfechos secundários e análise de alguns subgrupos também positivas para a combinação de DAR ou ADT docetaxel. Então, o benefício foi independente se o paciente tinha doença de novo ou uma doença recorrente, o tempo para castração, o tempo, na verdade, para a progressão de dor, o tempo para algum evento sintomático esquelético, assim como o tempo para novo tratamento positivos para quando a gente adicionava darolutamida, ADT mais docetaxel. Em relação à toxicidade, o que a gente consegue ver é que basicamente essa toxicidade ela advém do uso da quimioterapia, então o docetaxel foi quem realmente trouxe toxicidade, então a gente vê que a toxicidade é muito semelhante em ambos os braços, e quando a gente avalia toxicidade relacionada ao uso de darolutamida, né, toxicidades que seriam mais específicas à darolutamida, né, a classe do tratamento, a gente consegue ver que não há uma grande incidência de toxicidade para os pacientes, estão mostrando que realmente a adição de darolutamida foi segura para esses pacientes para o tratamento do câncer de próstata metastático sensível à castração. Acho que as grandes perguntas, e aqui a gente vai querer ouvir bastante do Neeraj, é que apesar de, desde 2014, com a apresentação na plenária da ASCO, 10 anos depois do docetaxel mostrar um ganho de sobrevida global no cenário resistente à castração, a gente teve um ganho no cenário sensível com o estudo Charted, mas desde então a gente vê que a intensificação de tratamento é muito pequena, globalmente falando. Aqui eu tenho dados de vários lugares, inclusive uma publicação do próprio Dr. Neeraj que está aqui conosco. Por que será que isso acontece? Custo, acesso, performance do paciente, desejo do paciente, conhecimento científico, ou qual o motivo que isso acontece, como a gente deve ou pode melhorar? Outra pergunta é se todos os pacientes são iguais, e com isso a gente hoje, sem grandes biomarcadores e avaliando só aqui volume ou momento de diagnóstico de doença sistêmica ou sítio de metástase, são suficientes para escolher o tratamento mais ou menos intensificado para esses pacientes, uma vez que a gente consegue ver prognóstico muito diferente de pacientes aí de acordo com volume, tempo de diagnóstico de doença metastática ou local de doença metastática. Será que a terapia tripla ela é melhor que a terapia dupla, mas usando um parceiro, não quimioterapia, mas um novo agente hormonal? Então essa é uma pergunta que a gente tem e acho que infelizmente a gente não vai ter uma resposta com um bom nível de evidência. Será que qualidade de vida é um fator importante, uma vez que a gente tem aí diversas opções para esse paciente? E será que todos os pacientes que podem receber quimioterapia devem receber terapia tripla? Então, vou passar aqui já para as nossas discussões, Adriano. So, we'll start our discussion. Dr. Neeraj, thank you again. So, of course, I have to start with you. And my first question, based including your data about the adherence to intensified therapy, what do you think about the monotherapy with ADT, double therapy with any combo or triple therapy in patients with MCSPC?
Thank you, Andrey. There is no role for monotherapy with ADT, in my view, in patients with metastatic castration-sensitive prostate cancer. There may be few patients, I would say 5 to 10% patients at the most, which we see in our clinics who are older, who are having multiple cardiac issues or just frail and do not have a life expectancy of more than 2 years. So an example is a 93-year-old man who comes to my clinic with coronary artery disease, ejection fraction which is 50%. So it's not like completely normal, but otherwise it's fine. It's healthy otherwise, and it's not doesn't want to be very aggressive about treating his disease. So we are seeing a 93-year-old man with a borderline history of congestive heart failure. Although ejection fraction is improved with medications, in this patient, I would not hesitate using single-agent monotherapy or single-agent ADT. But then beyond those patients, I think there is no justification for not using intensified ADT with either NHT or docetaxel chemotherapy. And we can have a separate discussion about that. So you asked me the question about role of ADT monotherapy and the doublet therapy so far, right?
Yeah, sure. And I love your comment.
Dr. Neeraj, if you want to open your camera and we can see you because you are close here. I don't know if you have the camera there, but
I have the camera ready.
I want to see you. I want to see you.
And I'm not able to see you guys. So I was going to ask
you can see us?
No, I'm not able to.
Oh, okay. So
I'm so sorry.
Okay, no problem.
May I just log in again?
Okay, let's move on.
Yeah, I love your comment because one of these days, a few weeks ago, there was a poll here in Brazil asking what percentage of our patients as medical oncologists are being treated with doublet therapy. I mean, ADT plus a newer mono agent. And surprisingly, it was less than 20% of patients were getting doublet therapy. And I agree with you. I mean, nowadays, unless you have that very selective population of elderly with high comorbidity, everybody should be getting at least two. And now we're talking about a third drug, and this third drug is chemotherapy. In my view, the ARASENS trial kind of puts it aside the charted patients. I mean, the patients to get only chemotherapy. In my practice, very few of the patients are getting chemotherapy like the charted or Stampede trial. In your practice, do you foresee patients getting chemo and darolutamide, or you still think there is you still need more data to start that practice in every patient?
That's a great question. I'm still trying to work on my camera. I'm very sorry. I don't know what is happening. I cannot see you guys also. Let me try one more time again.
Okay. Yeah, I don't know what happened. We are trying to fix it, but we can go on.
Yeah, we can keep the discussion.
Yeah.
We're able to hear you.
Are you seeing my PowerPoint presentation?
It says you are in the backstage. I need to be moved from the backstage to the.
You can see the PowerPoint presentation, Neeraj?
Yes, I can see the PowerPoint presentation.
Okay, so no problem. Let's go on like this. Yeah.
Okay, thank you. So, and I just want to tell you, it says I'm in the backstage. So somebody may need to move me into the main stage. Regardless, so what is the role of triplet therapy? That's the question here. I personally think, so first of all, we saw in ASCO last year, in multiple databases, Medicare database, thousands of patients, commercial databases in the US, and databases in a Veteran Affairs Hospital, which is a hospital for veterans who have served in the US military, where you would imagine insurance is not an issue. So our data from the VA databases, or results from VA databases, results from commercially insured patients, all have a very common theme. In the US, only 30% patients were receiving doublet therapy. So 70% patients were receiving monotherapy until 2019. And I think it has improved last year in 2020 and 2021. And in my assessment, 40 to 50% patients are receiving doublet therapy. So still there are 50 to 60% patients in the US who are not getting doublet therapy, who are getting only monotherapy. So there you go. I can see you guys now. So the question is, let's work on the doublet therapy first. So that's my number one take. And then find out why patients are not getting doublet therapy, and then work on triplet therapy. So who is the candidate for triplet therapy, in my view? So look at the RSN trial. We saw patients who were eligible to receive docetaxel as the criteria. So I'll stick to that criteria. I would say RSN trial showed that if you add darolutamide to the ADT plus docetaxel in patients who were starting docetaxel chemotherapy. So if you think somebody needs to start docetaxel chemotherapy in addition to ADT, I think adding darolutamide is a standard care for those patients. RSN trial also answered the question that adding a novel hormonal therapy to ADT plus docetaxel backbone improves overall survival. It did not answer the question, however, that adding docetaxel to the ADT plus NHT backbone improves survival. So do we have any data where adding docetaxel to, say, ADT plus darolutamide or ADT plus apalutamide or ADT plus enzalutamide improves the survival? Answer is no, we don't have the data. So my practice, I offer docetaxel to approximately 20% patients in my clinic of time. These are the patients, practically speaking, I'm not talking about the New England Journal article, I'm talking about my practice right now. What I do in my clinic. When I see patients with liver metastasis at the time of initial presentation, or when I do the molecular sequencing and I see patients who have PTEN loss, RB loss, P53 loss, or they have AR variants at the baseline, I know these patients are likely not going to do very well on NHT alone. If I start them on NHT, they may have androgen insensitive population among prostate cancer cells. I like to start these patients on docetaxel chemotherapy upfront. Sometimes I see patients who have extremely high volume disease, say 49, 50-year-old man. I recently saw widespread metastasis, and then patient also happened to have PTEN loss and an AR variant. I think in this patient, I did not hesitate with starting him on docetaxel chemotherapy. And then following piece 1 data presented by Dr. Karim Fizazi in ESMO, I started the patient on abiraterone. So these are the patients I would select for triplet therapy.
Great points. So let's move off to the next presentation. We are going to the resistant setting now. I will present the Preside trial. Here the scheme of the trial. Preside trial looking for a different approach in patients with mCRPC that progress with enzalutamide. So the design trial is patients with mCRPC that progress after enzalutamide to receive docetaxel with or without enzalutamide as maintenance therapy in patients who already progressed with enzalutamide before. The patient characteristics are almost the same. The only difference is the PSA value, but I don't think that is very important for the results of the trial. And the primary point of the trial was positive. That was radiographic progression-free survival. It's very important to highlight here that is a positive trial, but my question will be, it's a clinically positive trial? Because we have like 8 months against like 9 months in RPFS for this kind of patients. We saw that all patients had benefit of the maintenance of enzalutamide, and the second endpoints was positive too. There are a little bit more overall response rate in the patients who receive enzalutamide and docetaxel, mainly in patients who present with complete response for the maintenance therapy. Other questions is we actually don't know how to sequence patients in the mCRPC scenario. This may be only trial that look at it in prospective view, the use of one new hormone therapy followed by another one. And what we saw here is there is no good evidence for a new hormone therapy followed by another new hormone therapy. And that what we saw that adding new hormone therapy in patients who progress after enzalutamide, for example, the Plateau trial, it's a phase 4 trial looking at patients who progress after enzalutamide. To change it to abiraterone or to keep enzalutamide and add abiraterone, we did not see any kind of advantage to add abiraterone and keep enzalutamide for this kind of patients. So some challenges in the management of mCRPC patients. Is it possible to extrapolate the data in patients progressing on enzalutamide in the HSPC setting? I think that's a very important question here too. The Preside is statistically positive for the primary endpoint, but it's clinical relevant. Adding drug with the same mechanism of action did not add benefit, but adding a different mechanism of action maybe works in a subset of patients. And it could be some windows of opportunity for new combinations biomarkers to drive this kind of strategy. And how PIS1 are assays proper magnitude that we will discuss a little bit later. And in the future Preside trial, will change first-line therapy in patients with mCRPC. So I will leave my questions here. Dr. Neeraj, could we extrapolate the data in the hormone-sensitive prostate cancer setting?
Sorry, Andrey. I did not understand your question.
The data of keep the androgen receptor target agent in patients. The patients receive the androgen receptor target agents in the hormone-sensitive setting. When patient progress, we can extrapolate the data of Preside trial, keeping that androgen receptor target agent and adding those docetaxel for this kind of patient?
That's a great question. So first of all, regarding the Preside trial, the improvement in radiographic progression, improvement in PFS, the primary endpoint, was not clinically relevant for me. I think this is a great effort by the team, but less than 2 months of improvement in PFS was not sounding very compelling to me when the data were being presented. So I'll probably not change my practice of combining enzalutamide with docetaxel in the CRPC setting when these patients are already experiencing disease progression on prior therapy with enzalutamide. The question is, can this data be extrapolated to a hormone-sensitive setting? Is that correct? Or the opposite?
Yeah, he asked if this could be extrapolated and keep. I think you answered the question of keeping the enzalutamide while progressing. Let me add you another question. You mentioned doing a lot of molecular testings in some of your patients with NGS. Do you see any populations, let's say populations that did not have AR loss, that could be a subgroup that could benefit from maintaining AR antagonist? or do you think it's not relevant and we're not going to do it in any patients with this Preside trial?
As I said, even though study met the primary endpoint, and I think I applaud the author for doing this kind of study, because each one of us had this question in mind. I personally think data are not compelling enough for me to change my practice of combining docetaxel with enzalutamide in any patient population in the metastatic castrate-resistant prostate cancer.
Great point. I think my last question is how to use it, how to sequencing patients after PIS1 Arasense with the data of Magnitude Propel. I think we can present both trial, Adriano, and discuss this kind of questions right after the presentation.
Bom, então vou apresentar os estudos, essas são meus declarações de conflito. Então, apenas para contextualizar, o tratamento do câncer de próstata resistente à castração mudou muito nos últimos 10, 15 anos, né? Então, esses são uma tabela com todos os estudos, e eu vou chamar um pouco a atenção a esses dois estudos em negrito, que é o 302 e o Prevail, que são estudos em primeira linha, que mostraram um benefício de sobrevida global nessa população. E em segunda linha, recentemente, o estudo Profound foi aprovado, ou gerou a aprovação de olaparib no sequenciamento, então, desses pacientes pós-uso de um novo agente hormonal. E a grande pergunta que ficou é se o uso do olaparib com um novo agente hormonal ele é sinergístico ou ele é aditivo no tratamento do câncer de próstata resistente à castração. E num estudo de fase 2, já publicado anteriormente, a gente viu um benefício de sobrevida livre de progressão radiológica, tanto nos pacientes com mutações da recombinação homóloga de DNA, como nos pacientes que não tinham essas alterações mutacionais. E aí veio o ASCO GU de 2022 com dois estudos que a gente mencionou, então o Magnitude e o Propel. E o Magnitude, então, usou a combinação de niraparib com a abiraterona, comparado apenas com a abiraterona no tratamento de primeira linha do câncer de próstata resistente à castração. Esse estudo que foi feito o teste inicialmente, aqui 100% dos pacientes fizeram um teste de tecido, né? Então eles eram randomizados baseado na presença ou não do biomarcador. Nos pacientes com biomarcador negativo foi feita uma análise de futilidade após 200 pacientes e mostrou que não tinha nenhuma alteração, nenhum benefício da adição do niraparib, enquanto que os pacientes com o biomarcador foram então randomizados a receber niraparib mais abiraterona contra apenas biraterona, 400 pacientes, todos então novamente com alguma dessas alterações de recombinação, podia ser BRCA1, BRCA2, ATM, qualquer uma dessas outras que estão listadas. Quando a gente vê a análise, a tabela de grupos, o que chama atenção é que 24% dos pacientes que receberam niraparib tinham doenças viscerais, enquanto só 20% não tinham, e o NICOG, pacientes basicamente assintomáticos, 30% dos pacientes eram sintomáticos. O estudo, então, mostrou um benefício de sobrevida livre de progressão radiológica, tanto quando a análise pela central, que era a análise primária, quanto pelo investigador eram positivos para a combinação. E quando a gente vê o subgrupo de pacientes com mutação BRCA1 e BRCA2, mostraram que esse benefício, o hazard ratio, era até maior para essa população, que já era esperado, foi o que a gente viu no estudo Profound. Na análise de subgrupo, parece que todas as subpopulações tiveram esse benefício do uso de niraparib. Os endpoints secundários, e aí inclui a sobrevida global, ainda não estão maturos, né, porque apenas 27% das mortes ocorreram, mas tanto em termos de taxa de resposta, como tempo para quimioterapia, tempo para progressão, e até a qualidade de vida não foram interferidos com o uso da terapia combinada. Em termos de efeitos adversos, não houve nenhum aumento de toxicidade. Uma preocupação grande era em relação a eventos cardiovasculares, não houve um aumento significativo dos eventos cardiovasculares, apenas uma toxicidade hematológica um pouco maior, principalmente com anemia e trombocitopenia. Passando para o estudo Propel, um estudo muito parecido, porém um pouco diferente, a gente vai discutir um pouco isso, usou a combinação de olaparib com abiraterona contra apenas abiraterona, também no mesmo cenário de primeira linha resistente à castração. Aqui é um pouco diferente, né? Então, eram pacientes all-comers, pacientes que tinham mutação ou não, e aqui A gente pode discutir um pouco mais com o Neeraj como ele entende o teste, como foi feito o teste desses pacientes, mas aqui foram 800 pacientes, 400 em cada grupo, e também o desfecho primário era sobrevida livre de progressão radiológica, embora aqui era baseado no investigador e não análise central. E aqui apenas 27% dos pacientes tinham mutação de recombinação homóloga de DNA, enquanto que 70% da população não tinha essa recombinação, e aí a gente pode discutir, né, Andrey, 30% eram só de ctDNA, então talvez tenha aí um falso negativo no meio do caminho. O estudo foi positivo, né? Então, o desfecho primário com benefício aí da sobrevida de livre progressão radiológica, um hazard ratio 0,66, 24 meses contra 16, tanto na análise do investigador quanto nessa análise análise central, e todos os subgrupos mostraram esse benefício. Os desfechos secundários da mesma forma, todos positivos, sobrevida global ainda imaturo, porém com uma tendência melhor para a combinação, a taxa de resposta aí 10% melhor para a combinação sem interferir na qualidade de vida, e efeitos adversos também, um pouco de aumento só de anemia, mas sem grande toxicidade em questão de eventos tromboembólicos. E as perguntas que ficam aqui é só um quadro de semelhanças e diferenças que a gente comparou do magnitude com o Propel, e as perguntas que ficam estamos prontos para essa combinação? Para mim, algumas perguntas que eu vou deixar aqui para o Neeraj responder, e agora eu mudo para inglês e a gente já começa a discussão. So, Neeraj, I'll leave these questions open for you to kind of address. So, are we ready to these combinations of NHA and PARP inhibitors? To me, it's still unclear on how and when those patients should be tested. Should be tested with the tissue from the prostate biopsy, should be tested with the new metastatic progression, should we test with ctDNA? If the ctDNA are negative, should we test the tissue then? And my biggest concern on this is that we're trying to get biomarkers to treat prostate cancer patients. And now with the Propel data that all comers do benefit, are we doing a step back? And should we stop testing these patients and just treat everybody with PARP inhibitors? So what are your comments about these two trials presented at ASCO?
All these are fantastic questions. Both trials have basically got us started on thinking more on what to do with these two combinations once they're approved by the regulatory bodies. So I think the first step is to see when they are going to be approved and then talk about how to use these combinations. Answering the first question, are we ready to use these two combinations in our clinic? In my view, we have already seen olaparib and rucaparib being approved in prostate cancer patients in the mCRPC setting after disease progression on a novel hormonal therapy in case of olaparib, or hormonal therapy plus chemotherapy in case of rucaparib. So there is no doubt that these agents work in patients who have homologous recombination repair defects. These two trials, no doubt in my mind, have established that the combination of abiraterone with either magnitude or with either niraparib in the magnitude trial or with olaparib in Propel trial improved outcomes. In this case, radiographic progression-free survival in patients with biomarker positive metastatic castrate-resistant prostate cancer. There's no doubt about that. And once these combinations get approved, I'm going to use any of these two combinations in my patients. I think the bigger question now, we can focus on that right now, what to do with patients who are biomarker negative. So let's look at the magnitude trial first. Magnitude trial did test 233 patients who were HRR negative and did not find any improvement in PFS, which was defined as a composite PFS, which would have been determined by PSA progression, which may not be the ideal endpoint in this setting. So that's the criticism of the magnitude trial for a second, pros and cons. If you look at the Propel trial, it's a much larger patient population of HRR negative patients. As we saw, if you look at the total number of patients, 700 plus patients, almost 28% patients had HRR positive or biomarker positive. It means almost 450 patients plus, or maybe close to 500 patients, were not HRR positive. And based on what was discussed, or based on what was presented so far, what has been presented in the GUASCO, what was present in the abstract in the GUASCO, those patients were detected or determined to be HRR negative by ctDNA testing. We know that ctDNA testing is not absolute, especially in the first-line mCRPC setting. It is possible that tumor burden was not high enough, and CFDNA could not really extract enough ctDNA to determine whether these patients were truly negative. So is it possible that the so-called HRR negative patient population in the Propel trial could have been HRR positive? So I think we need the tissue data to really see if the hazard ratio of 0.76, it is an impressive, clinically meaningful hazard ratio. I want to see if this negative, so-called negative patient population is indeed negative by tissue testing. And I'm sure investigators have the data, company has the data, because they did say patients were tested by tissue testing and the ctDNA testing. So I think it's a matter of time when the manuscript is published, or we can look forward to data being presented on whether the negative patients in the HRR, in the Propel trial, were indeed negative by the tissue-based testing. That's number one. And number two is, I would like to see, I will be quick, I would like to see delay in the chemotherapy use, delay in pain progression, delay in opioid use, and overall survival data down the line, how these data pan out. I'm not saying overall survival is must for me, but I would like to see the delay in other clinically meaningful endpoints in this patient population, specifically in HRR negative patients. Please go ahead.
So, Neeraj, we can see you now. Great. This week I discussed with Dr. Antonorakis in another meeting about this 20-30% of patients who did only ctDNA tests in the Propel trial. And unfortunately, we will not have this question because these 20-30% of patients have archived tissue, but it wasn't possible to test because the quality of the material. So I think that this answer will never have because this is one comment here. My question is, an unselected population, looking at Propel data in an unselected population that the combination are positive, with another trial that is less, we discussed less this trial, but have the same results, the ACEs trial. How to interpret the data of Propel trial, the combination of olaparib with abiraterone in an unselected population, and the results of ACEs trial with apalutamide and abiraterone in the same population with the same results, the RPFS, and the number is really, really similar. Why we are discussing one and not discussing another one? So we will use in a biomarker positive the combination with PARP inhibitor, in a biomarker negative the combo of the ARTA.
Yeah, first of all, ACEs trial only showed delayed in radiographic progression-free survival or improvement in radiographic progression-free survival. It did not show delay of chemotherapy use. It did not show delay of opioid use. It did not show any other clinically meaningful endpoint to be improved with the combination of apalutamide and abiraterone. So I think that is the big difference between the Propel trial results and the combination of apalutamide with abiraterone. So, as I said, Andrey, to start with, we saw Dr. Fred Saad presenting delay in radiographic progression, as well as delay in chemotherapy use, delay in opioid use, delay and radiograph and overall survival trending in right direction. We saw all those clinically meaningful endpoints, which we did not see in the ACES trial. So I think that's a big difference. I am not saying that we should start practicing and using abiraterone and olaparib in unselected patients. Well, we cannot. The combination is not approved in the and is not available in the clinic. But if you show me down the line that combination of abiraterone with olaparib not only delays disease progression in a significant fashion, but also delays chemotherapy use, opioid use, and improves overall survival, and which doesn't have to be statistically significant to me. But I want other clinically meaningful endpoints to be positive. I think I would consider the combination. And I would like to bring to your attention one more thing. There is another trial, TALAPRO-2 trial, which is also testing the combination of a hormonal therapy, such as enzalutamide in this case, and a PARP inhibitor, talazoparib. So enzalutamide with talazoparib versus enzalutamide is being tested in patients with metastatic CRPC, first-line therapy setting. And that trial should be reporting in the near future. And I think that trial will also shed some light whether on this matter, whether the combination of NHT plus PARP inhibitor is indeed active in unselected patient population. So I think that may be a tiebreaker for us, all of us. So bottom line is, I want to see more results, especially in the HRR negative patients in the PROPEL trial, how other clinically meaningful endpoints are doing. Chemotherapy use and the pain progression and overall survival trends.
Since you mentioned the TALAPRO and talking more, going a little bit deeper on the PARP inhibitors, do you believe there is a difference between the drugs? Are they all the same? Or are we seeing difference between the magnitude and PROPEL just because maybe olaparib is better than niraparib? And how about the other PARP inhibitors? In Brazil, we only have for prostate cancer approved olaparib. Do you think there's a difference between them?
We know that these PARP inhibitors have not been compared to each other in a same trial. So obviously, preclinical data shows differential selectivity for PARP enzymes, for PARP trapping, for synergy with novel hormonal therapies. So we can have a separate session, I can assure you, on the preclinical efficacy or preclinical data of these drugs, showing how different they are. But so far, in my view, we have not had seen the preclinical differences being tested in clinical settings. So obviously, they have not been compared with each other. So I will not say one PARP inhibitor is better over another in a particular setting. But we do know that dose of niraparib, which was used in the magnitude trial, was 1/3 lower than what has been used in the ovarian cancer, because it was considered or perceived to be, or it was found to be toxic in the combination of abiraterone. Could that have played any role? I do not know. But we know that niraparib dose was slightly reduced by 1/3 almost. Olaparib was not reduced. In case of TALAPRO-2 trial, talazoparib is a different PARP inhibitor. Obviously, has different, we can expect some differences in efficacy and toxicity. But ultimately, I believe clinical trial results will establish whether talazoparib is a better PARP inhibitor or not in the combination of enzalutamide. So if you see better safety profile and efficacy profile, I would say yes, it seems to be a better PARP inhibitor. But if it doesn't, then jury is out. So that would be my question, answer to your question on the comparison.
One last quick question. You mentioned already that to you, all patients with any HRR mutations, you'll probably be treating with the combination of a PARP inhibitor and abiraterone. in the US, the profound was approved for all the mutations. In Europe, just for BRCA1, BRCA2. Here in Brazil, we added the ATM. Do you think that the type of mutations affect your indications, or are you going to indicate the combination for all the mutations, or maybe just for the BRCA2 that we know the curve was much better and the hazard ratio was much better for that subgroup?
I will add a comment here. Do you believe that PARP inhibitor is effective in other mutations than BRCA1, BRCA2, and ATM, or even in ATM in general?
Yeah. So I do have my doubts about ATM, obviously. We know, all of us know, that PARP inhibitors are differentially active in BRCA2 patients. I think they are most potent in BRCA2 patients. Also depends upon the allelic class, monoallelic class versus biallelic class. So we can go into individual biomarkers and we can discuss again, have another session on this. But I think two mutations. One is ATM. I'm not convinced that PARP inhibitors are as active in ATM as they are in obviously BRCA2 and BRCA1. May not be, you may not find a positive trial if you just accrue a ATM patient population who has ATM only mutation. You may not have that trial ever, but I think ATM has definitely a less efficacy with PARP inhibitors. I think based on my own clinical experience, CDK12 mutation doesn't seem to have PARP inhibitors do not seem to have efficacy in the CDK12 mutation as similar to what we saw with BRCA2 or BRCA1 mutation. PALB2 mutation is more sensitive, I think, to PARP inhibitors. CHEK2 mutation is somewhere in the middle. So I think Andrey and the panel members here, we can have an ongoing discussion, long discussion. But I think we need more data to see how these PARP inhibitors are differentially active in individual mutations. I think the subsets are so small that it's difficult to glean the ultimate efficacy and safety in individual subset. But ATM is least active. PARP inhibitors are least active in ATM, I think, ATM patients.
Neeraj, it was amazing to discuss with you. We could stay here for a while. We have Petros waiting for us to the next session. Thank you very much. Wake up early on Saturday to discuss with us. Hope to see you again soon. And thank you. Let's move on to the next session with Petros and our colleagues here. Thank you, Neeraj. Have a good Saturday.
Thank you very much.
Bye-bye.